discussing management of the patients with burn injuries, part 2. All right, here's our list of objectives for this PowerPoint. Be sure to review these. This would be good to know as a good study guide for your exams. All right, so keeping in mind the geriatric population with burns, normal aging puts patients at risk for injury because of possibility of unsteady gait, limited eyesight, diminished hearing, and the fact that wounds take longer to heal. And in the geriatric population, pneumonia is a frequent complication. And so because more complications in the emergent and acute phases of burn resuscitation because of pre-existing comorbidities. Weaning from ventilators, if that's necessary, is also a challenge for the elderly. So the number one thing you can do for the geriatric population is work on education and prevention of burns. So there are 3 phases to a burn injury. Table 62-3 is a good breakdown of that. You have the emergent phase, the acute phase, and then the rehabilitation phase. Emergent phase is the onset of injury through the completion of fluid resuscitation, and then the acute phase goes from beginning of diuresis to wound closure, and then the rehabilitation phase is from when the wounds are closed and then just getting them back to baseline into their optimal levels. Here is that chart 62.3 just for a good review. Definitely be worth paying attention to and making sure you have a good idea where everything falls on it. All right, 624. So in the emergency table 62.4 is the emergency procedures at a burn scene. So this is what you would be doing if you happen to be walking down the street and you see someone on fire. So it's good to review. Extinguish the flames, remove from the source, cool the burn, remove any restrictive objects, cover the wound, and then irrigate chemical burns. So like I said, on the scene care is your first priority is to prevent injury to you, right? So you got to make sure the scene is safe before you do anything. Second, then you're going to stop the injury, right? So if they're on fire, put the flame out, cool it down. If it's chemical burns, irrigate it with water. Then you're going to do your A, B, C, D, and E's. So it's establish your airway, your breathing, your circulation, and then you're going to look for disability, which is mental impairment as well. And then you're going to expose and examine your monitor exposure. Then you need to start your oxygen and large bore IVs. Large bore is 14 to 18 gauge, as big as possible. You're going to require a lot of rehydration for patients. Obviously remove restrictive objects and cover the wound. If you have a fresh sheet or fresh towel, if you're on scene, that would be what you would do. Do assessment surveying of all body systems to obtain a history and incident and permanent patient history. So and note, just underline, treat patients with falls and electrical injuries is for a potential cervical spine injury. Remember we talked about that in the last lecture about how your muscles can contract so hard and fracture long bones. Patient is then transported to the emergency department and fluid resuscitation begins. A Foley catheter is inserted. Patients with burns exceeding 20 to 25% of their body should have an NG tube inserted in place to suction, just to keep bowel rest, and to reduce future aspiration issues. Okay, patient is stabilized and condition is continually monitored. Patients with electrical burns should have an ECG, right? Getting your baselines, make sure you're monitoring those things. Address pain. So pain's going to be something you're going to be addressing all the way through every phase of patient's care. Only IV medication should be administered, keeping the patient NPO. Psychosocial consideration and emotional support should be given to the patient and family. Burns are extremely traumatic and for the patient and for the family. And so psychosocial considerations need to be taken from the moment you begin care all the way up through discharge and even through rehabilitation phase. There's going to be a lot of adjustment for these patients. Like I said earlier, establishing IV access is critical for fluid resuscitation. So you've got to get 1 to preferably 2 large bore IV catheters, 14 to 18 gauge. A urinary catheter is inserted to permit accurate monitoring of urine output. So we're gonna through your renal lecture and even through fluid and electrolyte lectures, urinary output is the proper, is one of the ways to monitor hydration, adequate hydration. So you're going to want to make sure you have strict eyes and nose on these patients. Anytime fluid resuscitation is initiated with burns greater than 20% of total body surface area to maintain adequate organ perfusion. All right, so the ABA fluid resuscitation formula for adults within 24 hours post. So this is within 24 hours post burn. You want to take any adults with you add up their total body surface area that includes second, third, and fourth degree burns. Superficials are not part of the equation. So you've got second, third, and fourth degree burns. You add the total body surface area, multiply it by the patient's weight in kilograms. And for thermal and chemical burns, you're going to multiply by 2 mils of LR. For electrical burns, they require additional hydration. So you're going to take your total volume of second, third, and fourth degree burns, multiply it by the weight in kilogram, and multiply it by 4 mils of LR. And that'll give you your total volume of resuscitation the patient should need in the first 24 hours. So remember the last lecture we talked about your first your first wave of edema happens within the first 4 to 6 hours of your first fluid shift starts occurring in the first 4 to 6 hours of burn. So half of that volume that you just calculated is going to be given over the first 8 hours of burn injury. And then the second half will be calculated over the next 16 hours. So this resuscitation formulas are only a guideline. It's generally going to be titrated hourly based on the physiologic monitoring of the patient's response. Right? So you're going to be monitoring your eyes and nose. That's why you need a Foley to make sure you have proper urine output. Okay. Remember, timing is the most important consideration. Calculating. So this is the fluid needs for the first 24 hours of a burn. You want to make sure this is at the time of injury, not the time of treating the facility. So if the patient's burned at 3 o'clock, but they don't get to the hospital until 5 o'clock, you're going to have to calculate that volume still from, you're still to calculate your volume, but you're already 2 hours behind on your fluid resuscitation, so you're going to have to increase your rates to catch up. Remember, so we talked about this already, adequacy of fluid replacement assessed by urine output. For regular patients and burns, 0.5 to 1 mils per kilogram per hour, so roughly 30 to 50 mils per hour is what you should be expecting. For electrical patients, remember you need significantly more urine output, so you're looking at 75 to 100 mils per hour. You're going to want to maintain blood pressures greater than 100 millimeters per mercury over systolic for urine output of 30 to 50 mils per hour. And you're going to try to be monitoring your serum sodium levels to try to keep them near normal levels. So this is just some list of other formulas that are used to calculate burns that you could see out in different facilities and even different books. So just note, you always have to adjust the formulas to reflect initiation of fluids at the time of injury. So that's the one consistent thing, is no matter what you're looking at, when the injury occurred and not when they arrive in the hospital. So in the emergent phase, these are the main things you're looking at. You got fluid and electrolyte shifts. So you're going to have generalized dehydration. Like I said, as the injuries occur, your vascular becomes more permeable, so your plasma moves out of the venous system, and with it can possibly, which then reduces your blood volume and causes hemoconcentration. And so you're going to have, if you have less volume, you have decreased urine output. The trauma to the cells, like I said, releases potassium into extracellular fluid, causing hyperkalemia. So sodium traps in the edema fluid and shifts into cells. So you can have hyponatremia as sodium follows the albumin. And then you do run the risk of metabolic acidosis occurring. Think about your fluid and electrolyte lectures. Remember what happens when you have hyperkalemia. You're going to be shifting hydrogen ions out of the cell to absorb potassium, so you can increase, and so you're going to have an increase of hydrogen ions leading to metabolic acidosis. Patient's temperature must be monitored because hypothermia may develop rapidly. Manipulation of the environment is necessary. That's why you want to worry if you've got a large damage to your skin, you can't maintain your adequate temperature. So temperature less than, and just keeping in mind less than temperature less than 35 degrees causes vasoconstriction, which may increase tissue ischemia and necrosis. So if you have burns and the patient's cold, they're going to be even less perfused. So keeping that in mind, that's why you want to, another reason aside from infection prevention is to maintain proper warmth. Okay, if the burn exceeds 20 to 25%, nasal gastric tube is inserted and then connected to low intermittent suction. All patients who are intubated should have nasogastric tubes inserted to decompress the stomach and to prevent vomiting and aspiration. So obviously, we talked about this a couple times now. If it's electrical burn, a baseline electrocardiogram should be obtained and continuous cardiac monitoring should be initiated. You're going to be monitoring vital signs and hemodynamic status, monitor a fluid volume deficit, and then that's going to be assessing the extent of the burn. Chart 62.6 is a good chart to review for this. Using nursing, so potential complications and collaborative problems, if you're looking at acute respiratory failure, distributive shock because of fluid loss, acute kidney injury because of fluid loss compartment syndrome, based on the fluid, moving the vascular, paralytic ileus, we talked about early in the previous lecture, and curling ulcer is another concern. So moving to the acute or intermittent phase is 48 to 72 hours after injury. You're going to continue assessment and maintain respiratory and circulatory support, monitoring fluid electrolyte balances, GI and renal function, prevention of infection. So this is where you're going to start doing burn wound care, pain management. Like I said, pain management is going to happen no matter what phase you're in. And then you're going to be modulation of the hypermetabolic response, early position mobility. So remember, you're going to have, whenever you're in shock, your body, produces more glucose and it requires more energy to heal. So you're going to go into a hypermetabolic state. So you're going to be requiring more energy and more calories to fight that. So during this phase, you're going to be working to restoring fluid balance, preventing infection, modulating the hypermetabolism, promoting skin integrity, pain, strengthening coping strategies, supporting the patient families, and monitoring and managing complications. So during the acute phase, you're going to have a lot of fluid electrolyte shifts. So fluid re-enters the vascular space from the interstitial space. So you're going to have hemodilution. So you're going to have having increased urinary output. Sodium's lost to diuresis due to dilution and as fluid enters the vascular space. So you once again, you have to worry about hyponatremia, so you're going to be monitoring your sodium frequently. And then the potassium shifts are going to move from the extracellular fluid back into the cells. So you got a risk for hypokalemia as well. Airway obstruction is caused by upper airway edema. It can take as long as 48 hours to develop. So this is another thing you're going to be watching, and we mentioned in previous lectures that you're going to be watching your airway depending on where the burns happen. Patients can improve and worsen unpredictably or almost on a daily basis. So daily to hourly basis, they can be changing status. To help monitor, to help lessen the effects of edema, you're going to want to raise the head of the bed. If you start noticing stridor or dyspnea or ominous late signs of impending airway obstruction, so then you definitely need to be getting some support to help their airway. So early endotracheal intubation removes the need for emergency tracheostomy after respiratory is discovered, because if you have swelling to the point where you can't get a endotracheal, you can't be intubated, then they're going to have to do a tracheostomy. So the only thing is they're always weighing the risk versus rewards. So intubation and mechanical ventilators are significant contributors to infections. So if they do end up intubated for this, the goal is to get them extubated as soon as possible. So capillaries regain integrity 48 hours more after the burn. Fluid moves back from the interstitial space to the intravascular compartment, and intrinsic diuresis begins. So basically what's happening is all your edema is now going to return back to normal, so it's going to start reverting vascular, and you're going to be voiding out all the fluids that we're replacing. So you got to keep in mind if cardiac or kidney function is not adequate, you're going to worry about fluid overload may occur. So you're going to be watching for heart failure. So that's going to be looking for, your pulmonary edema, and then also if watching those signs. You can also, hyperthermia is common in patients after the burn shock resolves. So there's a resetting of the core body temperature to patients who are severely burned. It results in the body temperature a few degrees higher than normal for several weeks after the burn. So just keep it. So once they're healing, they are going to have a portion of time where they're going to be hyperthermic. So part of the acute phase is going to be excisation and grafting. So it's surgically repairing the wound sites. So management of full thickness burns involves eschar removed. So it's removing the scar, the charred tissue down to subcutaneous tissue or fascia, and then graft is placed on clean, viable tissue, and then it's covered with autograft. And then there's donor sites can take it with a dermatome, and choices of dressings varies depending on the patient. Multiple strategy approach is crucial to preventing multiple strategy approach is crucial in prevention of and control of burn infections. So burn wounds must be protected from pathogens. Like we've talked about before, your skin blocks, and helps protect you from multiple infections. So since you've lost that barrier, you're gonna, as a nurse, you're gonna be monitoring for that. So proper management of burn wounds is to prevent wound deterioration. And wound cares are going to be prevent infection by cleansing and debriding the area with necrotic tissue. So you're going to several debridings. Typically, it's almost daily if they're in the hospital. Removable non-viable tissue and wound exudate and eliminate previous applied topical agents. So as you do treatments, you're going to be scrubbing and cleaning it on a regular basis. Promote. Your goal is to promote wound reepitheliation and our successful skin grafting. Wound cleaning, you can use hydrotherapy. There's a list on table 62.4 that has a good list of topical agents. So there's several forms of wound debridement. You've got natural debridement, mechanical debridement, surgical debridement, and then wound dressing and dressing changes and skin grafting. So going through skin grafting, like I said, pain, superficial and partial thickness burns are very painful. You have all the nerve endings there are not covered, resulting in just excruciating pain with exposure to temperature, pressure, air currents, and movement. So, a lot of care is taken that when you're doing pain, when you're doing dressing changes, when you're doing wound care, a lot of times patients will be given preemptive doses of medication, or even depending on the possible sedation if the wounds are that extreme. Full thickness burns, the nerve endings are destroyed, so generally the patient doesn't feel as much on full thickness burns, and a lot of times that leads them to underestimate how severe the injuries are. So like I said, burn injuries are considered one of the most painful types of trauma that a patient can experience. So adequate pain management must address background, procedural, and breakthrough pain. So they're going to have constant throbbing pain, the procedural pain, and then breakthrough pain. If they move, if they do things, it's going to be extremely painful. Most severe burns are a combination of partial and full thickness burns that influence the amount of pain the patient receives. So depending on how much full thickness might be less, but as partial is definitely going to be more painful. So you're going to you're going to do a lot of goal setting with your patients. Elimination of all pains, difficult if not impossible, without and have them be able to function and participate in their cares. So it's setting realistic goals with their patient on what's a tolerable level of discomfort. They're gonna it's kind of being realistic with the patient. They're gonna they've endured a traumatic burn. There's going to be some pain associated with it, but it's your goal is to work with them to find a level that would be acceptable. Like if a 3 is an appropriate number where they can still function and still watch TV without being completely, engulfed in the pain, or, whatever number they choose and work with. And then you work with them to help them keep it at that level. So IV use is during emergent and acute phases. So morphine, fentanyl, plus some other medications. You have, there's role of anxiety and pain. So, they're going to get anxious. Like if you go say we're going to do wound care, they're going to be very anxious based on they know it's going to hurt, and it causes a lot of stress. And then you've got effective sleep and deprivation of pain. People, just not sleeping well is going to cause increased pain and increased discomfort. So always work with the patient too between the doses, non-pharmacologic measures, relaxation, breathing, distraction, hypnosis, therapeutic tests, music therapy, humor. I know just taking care of some patients in the past, if you can have something on that's funny that you guys can laugh about while you're working on a cares, helps a lot. So prevent further discomfort, infection, and complications. Instruct the patient. You want them to pat, don't scratch. So that needs to be reinforced with patients when they're, as they're healing. It's gonna be itchy. And preventive, you can work with antihistamines and stuff and some of that, but it's going to be just uncomfortable. So teach them to pat the itching area versus scratching is important to teach. Burn injuries produce some large metabolic abnormalities, and patients with burns have great nutritional needs related to the stress response. And I talked about earlier hypermetabolism and the requirement for wound healing. So your goal of nutritional support is to promote a state of nitrogen balance and match nutrient utilization. So nutritional support is based on the patient's pre-burn status and % of total body surface area burned. Enteral route is preferred. Jejunal feedings are frequently used to maintain nutritional status, and that does lower the risk for aspiration. It's important to get nutritional support as early as possible they can tolerate. You want to work with carbohydrates, the most important energy source, and should account for 50 to 60% of the nutritional delivery. Fats should be provided in limited quantities. And then as you transition to oral, then you're going to transition to high protein, high calorie meals, and supplements are given. Definitely you're going to be consulting a nutrition with all the orders from the physicians to make sure the patient's getting the correct needs. There will be daily caloric intake counts to make sure they are taking in the appropriate amount of calories. So meeting the daily caloric protein requirements is crucial. It promotes healing. Like I said, you're going to involve a dietitian, high protein, high carbohydrate foods. A lot of times they'll have an NG tube in the patient, so the patient, if they eat what they can throughout the day and if the caloric needs aren't met, then they'll be getting boluses of the whatever the formula is that is ordered to help increase their caloric intake and nutritional intake. So when wounds are still healing, and still open, the burn patient is still in a hypermetabolic and highly catabolic state. So especially while they're still healing, they definitely need as much protein and nutrition as possible. There is the risk of hyperglycemia. So you've got, like I said, stress-mediated cortisol and catecholamine release. So effectiveness of insulin is decreased because of relative insulin sensitivity that occurs when in traumatic states. And then also be caused by if you're giving them constant, if patients are receiving constant formula, constant calories, carbohydrates, you could just start going into a hyperglycemic state. You're going to treat with either IV or subcutaneous insulin and do frequent monitoring. The one thing you're not going to do is decrease the feedings. The patients need the calories. That's important and imperative to them for healing. So you'll work with physician, you'll work with endocrine to help come up with treatments for the hyperglycemia. Okay, and this can happen without even prior doses of diabetes. Nutritional exercise is described as essential adjunct in the care of patients with burns. It helps attenuate the hypermetabolic response and increases lean muscle mass. So a lot of times during wound cares and dressing changes while the patient is already kind of pre-medicated for pain, it's a good time to do some passive and active range of motion. So you'll do some repositioning of the hand as you scrub. If it's a burn, stretching it out, moving the arm in the proper mechanics, moving it around, giving all the, because new tissue, as new tissue grows, it'll be shortened, causing contractures. So you want to keep stretching it out to make sure you can maintain proper range of motion. So collaborative problems and potential complications is you still have, like I said, heart failure and pulmonary edema. You have infection and sepsis, respiratory failure, and then visceral damage due to electrical burns. So the final stage you're looking at is the rehabilitation stage. Rehabilitation stage is as early as possible in the emergent phase and extends for long periods after the injury. So you're also going to want to focus on wound healing, psychosocial support, self-image, lifestyle, and your goal is to restoring maximum functional ability so that the patient can have the best quality of life. They may need reconstructive surgery or vocational counseling to support groups may assist the patient. Remember, and this is something that should have been talked about from the beginning, from the initial injury all the way through to now. Common complications in rehab phase is skin contractures. Notice the tightness of the skin around the neck. And then you also have your joint contractures. See, it's pulling everything underneath. So that's why you want to make sure you're doing range of motions and those things. Be sure constant encouragement and reassurance. Reassure the patient their feeling, their parents, their feelings during this period of adjustment are normal. Definitely want to keep them in touch with any counseling as needed. Help maintain the patient's morale. Rehabilitation can be a slow process and probably extremely painful. So keeping a positive attitude is huge. And then talking to the patient, because society puts such a high value on physical beauty, that could cause a lot of psychological distress. So being there for them, discussing their fears regarding life as they once knew it. I think there's going to be role changes, loss of function, return to home life, financial burdens. There's going to be a lot of changes this family, patient's going to have to go through. So getting them to proper support and proper understanding is crucial. Some different care instructions. You got mental health. You're going to go through skin care when they go home, different nutrition, pain management. Encourage both the patient and the caregiver to participate in the care. Skills for addressing changes, wound care. Like I said, reconstructive surgery is frequently required after major burns. Creams that they can use, you want to recommend water-based creams, Vaseline, Intensive Care, Sween, Complex 15, for example, should be used on healed areas. It penetrates the skin and keeps skin moist, and it helps also decreases the itching and flaking. So patients and caregivers, like I said, they're going to have many emotional and psychological needs. This is traumatic to the patient, but also to the family and everyone that cares for them. So burn survivors, if let's say it was a group that he just happened to survive, they're going to have guilt and depression. New fears arise during recovery. Self-esteem may be affected. Spiritual, cultural needs. So just remember, you have, as a nurse, have an important supportive and counseling role as the patient struggles with their lives back on track. You could be you're going to be that positive person for that patient, the one person that's going to help them and be supportive of them and make sure they know they can continue on. Just keep in mind, though, it's difficult to deal with burn injuries. Like I said, they're very traumatic, and it's very traumatic to see the treatments and to see the effects as it goes through. You're going to witness deformities. There's very unpleasant odors, and the wounds themselves can be very, just very, very unnerving to see. Just keep in mind, the reality of the pain is that it accompanies the burn and the treatment. So burn nursing is physically, psychologically, and intellectually demanding. So if you happen to choose to go that route, do practice good self-care, because it's going to be really stressful. Here is my address and my links. If you have any questions or any concerns, you're welcome to reach out at any time. Thank you.